Welcome to the Psychiatry section. I'm Sam Asgharian, a Tulane University School of Medicine graduate. I'm going to walk us through a section that's deceivingly more difficult than you might think it would be. The reason for that is both in the vignettes and the answer choices, there are subtle differences that allow you to sometimes pick an answer that's deceivingly incorrect. And it regards a lot the timelines for the diseases, the adverse effects of the pharmacological treatments, as well as several other important factors, all of which we'll discuss throughout the psychiatry section. Throughout the psychiatry lectures, we'll pay attention to themes that repeat themselves. A lot of times, there might be the same treatment options, even if it's childhood or adult disorders, and treatment options might be the same in several different categories of psychiatric diseases. We'll also pay attention to topics that are important in other areas, such as pediatrics, surgery, and internal medicine, that we'll have to apply to the psychiatry section. We'll cover a wide breadth of topics, especially touching on the high-yield topics that you're likely to see on the exam. We'll also discuss differences and similarities. When we get to the psychotic disorders and the mood disorders, we'll be able to compare those once we get to Lecture 5 with the symptoms you'd see in someone suffering from substance-related disorders. And ultimately, we'll end on the personality disorders and conclude with a discussion on suicide that'll be important for the test. So today's topic is very important. It's very highly likely to be tested on the exam. There's a strong correlation between understanding the childhood disorders in psychiatry and knowing the development from the pediatrics section. The reason for that is a lot of the vignettes will give you clues as to where the child stands, and you'll need to know based on their age where that puts them. Are they delayed or adversely developing, in which case you can rule in a childhood disorder that we'll discuss today. I'm going to start with a broad overview of mental retardation. Mental retardation has to have deficits in both intellectual functioning, and that specifically means their cognitive abilities. You'd also look for signs of social adaptive functioning, their ability to perform daily activities. Unfortunately, as a male, I have to tell you that mental retardation is more frequent in boys, and the highest incidence is being in school-age children. I'm not going to spend too much time on this because one thing that you must note is that you can only rule in MR, or mental retardation, if a qualified physician, such as a psychiatrist, has administered an intelligence quotient test. The results of that test give you a number, and then that number gives you the ability to diagnose, if possible, mental retardation. So we'll discuss what those numbers mean in the following slides. So let's say the exam is administered and it comes back with an IQ range between 50 to 70. This is mild mental retardation. It's a level of functioning at the 6th grade level. Here, you would expect people to work and live independently. However, in difficult or stressful situations, they need extra help from family, friends, or physicians. Someone would have to support them through those times. If the IQ range comes back and it's between 30 to 55, you'd expect a lower level of functioning, and that's what you do see. You see people functioning at the 2nd grade level, and you're not going to see so much working and living independently as requiring supervision and support. And these people tend to do less well in stressful situations. Even in mildly stressful situations, they might need extra help. So moving down the range, and you would expect there to be congenital or genetic defects leading to this type of mental retardation. In severe, you'd get an IQ between 20 to 40. The level of functioning is going to be greatly depressed. There's going to be little or no speech, very limited abilities to manage self-care. Profound, here you would expect major congenital defects. These might be patients who were born without parts of their brain. They might be missing areas in those cognitive abilities that would allow them to function at a much lower range. Here the IQ range is less than 20. It's pretty much a test that doesn't have any response, especially if there's little or no speech. So they're going to need continuous care and supervision. So what are you going to do to treat mental retardation? Your best bet as a physician is to prevent it from occurring. So for instance, if there's a trisomy, what you want to do is make sure there's good genetic counseling to let the mother know that there's an increased risk of having another child with trisomy. It's actually a 1% plus her age-related risk. So that total gives you the total risk of having another child with trisomy leading to mental retardation. Good prenatal care and safe environments will also help expectant mothers, preventing them from possibly having children born MR. If it's due to a medical condition, such as PKU, this is when someone's born with an enzyme deficiency that prevents them from breaking down phenylalanine. What you do is you treat the disorder, so you'd limit and restrict the diet completely from phenylalanine or products containing phenylalanine. That'll prevent the toxic buildup and the subsequent mental retardation. You want to teach these people history and math, but you also want to pay close attention to teaching them life skills, possibly a trade so that they can work. I'm from Tulane, and that's in New Orleans, and there, during Mardi Gras, all the beads and decorations are manufactured in factories that employ people with mental retardation that have been taught through special education how to put those Mardi Gras pieces together. And a theme that pops up throughout psychiatry: if there's negative behaviors, you want to prescribe behavioral therapy to help limit and hopefully create a complete stop and cessation in that type of negative behavior. So now we're moving on to a very high yield topic. This is very likely to appear on your exam. It's something that the test makers enjoy testing you on. These are the pervasive developmental disorders. And what that means here, it's characterized by social, behavioral, and language problems. And it occurs before age 3. What's important is to know the wording. You might not necessarily see one of these distinct disorders as one of your answer choices. What may happen instead is that you're given answer choices. What do these patients have? Or what does this particular patient have? And it'll say something like mental retardation, deafness, and pervasive developmental disorder, and a couple other answer choices. So you might have been looking for Asperger, or you might have been looking for autistic disorder, but instead you're going to have to remember that it's a pervasive developmental disorder, and you'll choose that answer choice. So we'll start off with a very high yield topic. Autistic disorder has a greater incidence in boys than girls. Here are the key points. They're going to lack pure relationships, and that includes maternal and paternal relationships. Mom and dad will bring them to clinic, and mom and dad will report that the child doesn't bond with them, that the child doesn't hug them. There'll be poor eye contact, so the clinician will note that during the exam, the child doesn't make eye contact, and that social smile that's really important when a child's 1, 2, or 3 years old isn't going to be there. The speech is going to be absent or bizarre. And what do I mean by bizarre? It's another hallmark of autistic disorder. It's repetitive behaviors, including speech. So these children might repeat the same words or the same sounds over and over, and they may do that vocally, but in addition, they might have motor tics where they repeat the same maneuver with their face again and again. You might also note that in autism, there'll be stacking behaviors. This is very high yield. The parents will bring them into the clinic and complain that although they buy the child lots of toys, the child goes to the kitchen and continuously stacks cans of food over and over again. And ultimately, because of that communication barrier, that absent or bizarre speech, the children tend to get frustrated rather easily. And when they do, they lash out and they have this injurious behavior both to themselves or others. And here's a great diagram of an autistic child stacking cans in the pantry over and over again. This child might have tons of toys to play with, but rather than play with those toys or with any friends or siblings, he'd rather be in the kitchen stacking cans. And that's another good sign of autistic disorder. So again, those themes that keep repeating themselves in the psychiatry section. How are you going to treat autism? Very similar to how you're going to treat mental retardation. You're going to improve their ability to develop relationships, attend school, and achieve independent living. You might want to add those behavioral modification programs, especially if there's negative behavior. And if they're aggressive, this is a new theme that's going to repeat itself. Use antipsychotic medications. You want to calm them down or sedate them so that you can continue with the treatment plan and make sure that they don't harm themselves or others. So Rett disorder is going to be one that actually has a greater incidence in girls. This is going to be probably the only one in the childhood disorders that we cover that has that higher incidence in girls than it does in boys. It's similar to autism, but it's a much more pervasive disorder. Remember, we didn't say anything about physical symptoms for autism. Those children look like other children. For Rett disorder, there's going to be physical differences. It's a progressive encephalopathy. With that, you'd also see microcephaly. So their head size, remember, head circumference is something that physicians, pediatricians measure. So there'll be microcephaly. And hand wringing is a very common behavior. So if you see a girl with microcephaly, hand wringing, and loss of speech, you should really start to think about Rett disorder. If there's encephalopathy, you know that a lot of times that pressure in the skull can lead to ataxia. In addition, you'd see psychomotor retardation. And the treatment here is to treat the symptoms. If you can reduce the encephalopathy, you can reduce the ataxia and the psychomotor retardation. If there's self-injurious behavior due to that frustration, if they're hurting themselves, you want to add behavioral therapy. And because of that psychomotor retardation and all the other issues they might have, you can add physiotherapy as well for muscular dysfunction to prevent atrophy or misuse of their appendages. So what about childhood disintegrative disorder? That's a greater incidence in boys. There's normal development for 2 years, followed by marked functional regression in loss of language, social interaction, motor function, bladder function, and there's repetitive and stereotyped behaviors. So what you want to do here is note, let's say that the pediatrician says that they're normal for 2 years and all of a sudden there's regression in all these categories. You want to rule out an infectious or an autoimmune cause and then rule in childhood disintegrative disorder, especially if there's repetitive or stereotyped behaviors involved. So the treatment theme is going to keep popping up. You want to give them special education. You don't want to start teaching them physics or calculus before you get them to the point where they can develop relationships with their family and their friends and achieve independent living. If there's behavioral things that they might benefit from or negative things that you want them to stop doing, then you might want to add in behavioral modification programs. And as always, if there are dangers to themselves or others, you want to use antipsychotic medications to calm and or sedate them. So rounding out the pervasive developmental disorders is Asperger disorder. Again, greater incidence in boys, social and behavioral problems. This is very similar to autism. However, there's no language or, this is key, intellectual deficits. What that means is these children exhibit similar behavior to their peers, and as a result, the parents most likely won't seek help as early as they would with autism or Rett or childhood disintegrative disorder. They're preoccupied with rules, and this is what ultimately brings the parents into the clinic. Once they get older, there's no creativity, and they also get frustrated, very frustrated easily, if you try to get them to bend or break the rules that they've been taught. They do really well in things that are rigid, that are only one way to do them. So here you've got a picture of a child doing a puzzle. He's putting these pieces together, and there's really only one way to piece them together or form this, and ultimately that's what they tend to do best at. The treatment here is to improve their relationships with others. You want them to lead as normal of a life as possible. So here's our first case. The best part about all this is we'll take little breaks and apply our knowledge to cases, and they're very similar to what you might see on the exam. Gabriel is a healthy 2-year-old boy whose parents have taken him to the pediatrician. His problem started at 18 months of age when he did not speak much. He does not have much attachment to his parents and seems aggressive toward other children. So always for the test, note what's the ask, what's the question. Here, it's what's the most likely diagnosis. So take a look at that vignette and highlight the clues. Let's look at our answer choices. Now, let's narrow it down. He's not deaf because it's not that he doesn't speak, it's that he doesn't speak much. There's no psychosis here, so schizophrenia is ruled out. He's a boy, and he doesn't have those physical symptoms that we remember from Rett disorder. So C's gone. We can definitely keep autism on our differential. And learning deficit, these are basically throwaways. A lot of times on the exam they'll be there, but you need actual evidence of a learning deficit. There's none here. There's nothing that says that he has issues learning, he has dyslexia, or anything that's clinically a learning deficit. So hopefully, as you read it, you clued in too that D is the correct answer. And we discussed the issues here. Remember, he's a 2-year-old boy. That's right in that age range where you can diagnose autism. He doesn't speak much, so there's that absent or bizarre speech. And that, remember, the lack of social interaction. He doesn't have much attachment to his parents, and he seems aggressive toward other children. So we rule out the other answer choices, and ultimately we know if two that D said pervasive developmental disorder, we could have chosen D as well, but here it just said autism, and so we can pick D as our correct answer choice. So a very commonly tested topic is attention deficit hyperactivity disorder. It's obviously characterized by inattention. If it wasn't, it'd be one of the worst named disorders in all of medicine. But here you're looking for a short attention span or hyperactivity that interferes with daily functioning in school, home, or work. So there you go. You've got the child in the back right. Everyone else is diligent. They're doing their homework. Look at that girl in the front row. She's got an apple for the teacher, and everyone's doing work, but you've got little clown in the back making faces. It's not because he wants to be the center of attention so much as he actually has a disorder that prevents him from sitting still. Here's a really important point. For you to diagnose ADHD, the symptoms must be present for greater than 6 months. So it can't just be a sugar rush that the child had that day. And it usually appears before age 7. So always include ADHD in the differential if you have a child age 7 or less with symptoms that have been occurring for greater than 6 months. And note too that they may persist into adulthood. A lot of times the symptoms resolve before adulthood, but it can persist up until adulthood. You're also going to look for 2 areas where ADHD symptoms are present. At home, the parents will report that they interrupt, that they fidget in their chairs, that they run or climb excessively. They're unable to engage in leisure activities, so they actually can't relax and sit still long enough to enjoy reading a book or watching a movie. They talk excessively. The teachers at the school will say that they don't pay attention, that they make careless mistakes in their schoolwork, that they actually know the answers. This isn't an intelligence issue, it's an attention issue. And also, they don't follow through with instructions and they have difficulties organizing tasks. And that all goes back to them being easily distracted. A comorbidity with ADHD is a learning disability. So sometimes, too, if a child has ADHD that you've diagnosed, you also want to look for symptoms or a diagnosis of a learning disability. The treatment for ADHD is really important. So look at the first line treatment: methylphenidate and dextroamphetamine. Seems kind of counterintuitive that you would give a child who's hyperactive basically amphetamine. Methylphenidate and dextroamphetamine are both stimulants. As such, their side effects are what you would expect from giving someone a stimulant: insomnia, decreased appetite, and headache. For that reason, there's the second line treatment, which is atomoxetine. That's a norepinephrine reuptake inhibitor. It's less of a stimulant, and as a result, here's a big tip on the test. If atomoxetine is on the answer choices, choose that answer choice. The reason for that is on USMLE Step 2 CK, usually what you want to always go for is something that has a better side effect profile than the other possible treatment options. That'll be another theme that pops up. This might not be common in the wards. You might not see physicians doing this. But for the exam, the correct answer choice is the one usually that has less side effects. So atomoxetine would be correct in this case over methylphenidate and dextroamphetamine. A couple disruptive behavioral disorders that we'll discuss are oppositional defiant disorder and conduct disorder. Starting off with oppositional defiant disorder, there's an interesting fact here. It's usually noted by a physician around age 8. Incidence-wise, it occurs more often in girls than boys before puberty. But for some reason, after puberty, girls catch up quickly and there's an equal incidence in boys and girls after puberty. So what would you expect to see in a child who has oppositional defiant disorder? What you would expect is an argumentative child, temperamental, easily annoyed, blames others for their mistakes. So he or she doesn't want to take accountability for their actions. And they tend to have problems with authority figures. That's a big one. It's oppositional defiant disorder. They're rebellious. They stand up to authority figures, teachers, physicians, parents, people in authority roles. And they justify their behavior's response to others' actions. A very common thing that they'll say is, "You're making me do this. Why do you have to do that? And it makes me get angry." And here you've got a child that's just temperamental. He's throwing his temper tantrum. What you'd look for on the vignette are older boys. You want to rule out ADHD and rule in a personality disorder. And in addition, on the exam, be prepared to sometimes choose and answer choices normal behavior. Remember, when children get to their adolescent and teenage years, they do go to their rooms. They don't spend time with their parents as much as they used to. They play loud music. It's normal for them to do that. However, if it's interrupting their function in school and at home or at work if they're older, then you want to say that it's an actual disorder and not just normal adolescent or teenage behavior. If it is normal teenage behavior, then the treatment is simple. It's just reassurance. It's a phase of their life and they'll outgrow it. However, if it's oppositional defiant disorder, what you want to do is treat it by teaching the parents appropriate child management skills and getting them to lessen that behavior. Remember, there's no medical treatment here, there's no pharmacological treatment. You want to teach the parents how to basically curb that behavior in their child. A more severe behavioral disorder is conduct disorder. It leads to antisocial personality disorder, which we'll discuss when we get to more of the adult issues. But conduct disorder in a child, which you'd expect to do, is see this more frequently in boys, and in boys whose parents have that antisocial personality disorder. In addition, if they have parents who are alcoholics, then their child is more likely to have conduct disorder. And now we'll discuss the symptoms of conduct disorder. So what you would see here is persistent behavior where rules are broken. Rules that the parents set, rules that the school set, and rule that society has set, also known as laws. The behavior includes aggression towards others, so they'll be bullying children. Cruelty to animals is a big, big hallmark sign. If you see this on the vignette, they're terrorizing the neighborhood cats and dogs. You really want to make sure that you rule in conduct disorder. They'll get into fights or they'll use weapons. These are the children who bring knives, bombs, guns to school. And here you've got a great picture of someone bullying, aggressively fighting another child. That could be a very clear-cut sign of conduct disorder. They break laws. Remember, I said that they don't just break laws at home or at school. They'll vandalize and destroy property. They'll set fires and they'll steal items for others or lie to obtain things from others. They'll basically do whatever it takes to be a rebel, but more so than oppositional defiant disorder, they'll get in trouble with the law. And those rules that they'll break will include running away from home or breaking curfew. So how are you going to treat conduct disorder? You do want to intervene behaviorally using rewards for pro-social and non-aggressive behavior. When they act like they don't have conduct disorder, you want to reward them. And you always want to make sure that if they're aggressive, if they're harming others or animals, that you treat them with antipsychotic medications to calm or sedate them so they don't pose a threat to themselves or society. Let's apply our knowledge again on another case. We've got a 10-year-old boy seen by the school counselor after teachers complained of his behavior. He frequently becomes angry towards others and loses his temper. His parents report that he refuses to comply with house rules. He stays up past his bedtime and frequently talks back to them. So what you're going to do is look for the question. It's what is the most likely diagnosis? Hopefully you've got this one pretty quick. Let's take a look at our choices and what's the correct answer. You probably narrowed it down to A and D is the correct answer choice. Why is it not A? Well, because they're not breaking the laws or the rules. He refuses to comply with house rules, but he's not truant. He's not breaking curfew. He's not running away from home. He's not setting fires. That's a big deal, and that's where conduct disorder comes in. We haven't discussed Tourette disorder yet. We're just about to, but there's no tics here. There's no motor or vocal tics, so it's not Tourette. And there has to be a significant event that causes adjustment disorder. There's no stressor here. It doesn't say that he's moved frequently or his parents just got divorced or anything that would be something or a sign or symptom of adjustment disorder. And remember, learning disorder, be very wary of that. That's the one that you want to throw away most of the time because there's no evidence of it. You need evidence for a learning disorder. So we just looked at Tourette disorder on one of the answer choices. Let's discuss it more. It's another high yield topic for step 2. It's characterized by the onset of multiple tics. they last for greater than 1 year. So just because you have hiccups doesn't mean you have Tourette. It has to be pervasive and occur for greater than 1 year. It has to occur before the age of 18. And there are two types. The motor tics most commonly involve the face and neck muscles. So these are patients who can't hold their head still or their eyes still without constantly shaking their heads or blinking. The vocal tics, and this is a big hint, will include grunting, coughing, and throat clearing. They'll excessively clear their throat, or they'll dry cough when you think that there's nothing going on. There's definitely no pneumonia there, and that's another sign that it's Tourette disorder. So, a little bit more about Tourette disorder. It's seen more frequently in, can you guess? That's right, boys. The only one that we discussed today that's seen more frequently in girls is Rett disorder. Tourette disorder begins at age 7 and it's treated with dopamine antagonists. You might remember those from the antipsychotics. We'll discuss the antipsychotics in more detail, but note that antipsychotic meds that are dopamine antagonists are also used to treat Tourette disorder. An example of one would be risperidone.